So thank you so much, colleagues, to join today's session. I'm so grateful for the opportunity that we have today to have this moment to discuss this one of difficult, controversial concept, which is most of the time neglected in practice, but which is very critical to be addressed. Actually, we are approaching the end of psychosocial support. At this point in time. So we want to thank everyone for attending this session and appreciate the support you have given us at this point in time. And we hope we have learned something. The purpose of this platform was for capacitating us as palliative case consent. We understand that some of us have done it in school when we were preparing for service, and then we are doing a reminder now and again. So at this time, this module was specifically for psychosocial aspect of palliative care, following a pain and symptom management module. So we are looking forward to another module next year, which will be uploaded very soon, which will deal with hospice care or end-of-life care. So that what we'll be doing in 2025. We appreciate the support from our people in the team thus far in this project. So in our next module, we will be having these sessions conducted monthly so that we can be able to have time, some time to do other activities, as our team was overwhelmed in the past 2 years. So we are doing today one concept, which is sexuality in illness. So we'll be looking on the aspect of just understanding this concept of sexuality in illness. And then after this session, we will have the last session, which will be conducted on the 4th of December, which will be our last session for 2024. Which will be dealing with how do we engage communities in support of this life. And we hope we will all come together, finishing up strong in this module. So with that said, I would like to just go straight to the presentation so we can have time to learn, and I hope we'll have good discussions at the end of these sessions. So as we go to the presentations, whenever you have a question, you are free to put it on the chat or join discussions to unmute and say what you are saying. And we acknowledge your presence and cooperation that's far. And that's how learning happens. And then we will also be able to release CPT hours and certificates. Next week, when next section, when we finish, we will have the post test, which then enables us to be able to get participation certificates for this module that comes with the hours attended. So it's very important to finish that post test. Each session is 1 hour, 30 minutes, and we had 12 sessions. Actually, we had 13 sessions, so you can multiply that one by 1.5, which is around 18 or so hours accumulated in this module. So we print out the certificate. So may I go straight to the presentation for today? Thank you so much. I can see so can I share my screen this way? See what is here. I don't know what is happening now. Oh, here we go. Want us to see the presentation. So I will not be in a position to see your charts. So I will request you. Yes. So, I hope everyone can see my screen. Can you see the screen? Can everyone see my presentation?
Yes, Mr. Mahlangu.
Thank you. So today we will be looking at the concept of sexuality in illness. All what we will be trying to do is to give a summary of what is it all about and look at some of management and impacts on the patient's life and some of the things that can be done. And then we'll also look at the framework that we can use to do an assessment or follow in dealing with sexuality issues for patients and managing members. So that's what we are going to do. So we are going to look at that. We're going to look at the concept and impact and management, and then we will finish with the framework that we can write on to do it right. So that's what I can share. So then we'll start with what is sexual health, because we need to understand there's a difference between sexuality and sexual health. But WHO defines sexuality as a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, and affirmity. So whether you are sick, whether you are healthy, whether you have a disease or you have an infirmity or any dysfunction, you have what we call sexual health related issues. You are a sexual being. So, and then it requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having a pleasurable and safe sexual experience free of coercion, discrimination, and violence. So when we talk of sexuality, that's what it requires. For us to say you have a sexual health, or health that is sexuality that is health, I would say so, it needs to be respected, and it requires a positive and respectful approach. For that reason, it is incorporated into the palliative care, because whenever it is approached, it needs to be approached in a respectful and positive way. especially to the issues of sexuality and then the sexual relationship of that person. So for sexuality to be attained and maintained, the sexual rights of all persons must be respected and protected and fulfilled. So we need to understand this. Even if my patient is a cancer patient, he's had all these problems, but he's a sexual being, and for him or her to attain his sexual health, the sexual rights of that person must be respected, protected, and fulfilled without discrimination or prejudice. So then we go to the other term defined by WHO. There are other people who define this one. The Royal Nursing College does define it, but I like it from the WHO way. So as per WHO definition, sexuality is defined as a central aspect of being human throughout life and encompasses gender identities and roles, sexual orientation, eroticism, and pleasure, intimacy, and reproduction. So when we're talking about sexuality, this is what it all has. It has the sex itself, it has the gender, identities, and it has roles, and sexual orientations, it was eroticism and pleasure, intimacy, and it has the issues of reproduction. Experiential and expressed. So what I mean here is that sexuality is something experienced and expressed in the term in form of thoughts, and it is fantasies, desires, beliefs, attitude, values, behaviors, practices, roles, and relationships. So this is how we express our sexualities. So experience it this way, through thoughts, fantasies, and stuff. So we need to understand with patients we are dealing with. This is what we need to understand that this is how we all do that. And why sexuality can include all of these dimensions of a human being. Not all of them are always experienced and expressed. So we find that a person may have 1 or 2 or 3, but this is how it is expressed, and they go through that. And what we need to also understand that is that it is influenced by biological, psychological, social, economic, political, and cultural, legal, historical, religious, and spiritual factors. How you experience and express your sexuality is affected by these factors. So for that reason, we incorporate sexuality in illness, so we can see the impact of the illness on the patient's being and the patient's right of the sexual health. So the Royal Nursing College also defined it, states that sexuality exceeds the physical act of sexual intercourse. Not that it is not the act, but it's beyond the act. So the act is part of the sexuality, but it's beyond the sexual intercourse and varies in its meaning and importance, especially gender sexual attention. So this is what we need to understand about sexuality. So looking at the factors that are maybe grouping them in terms of the big clusters, which might be psychological, social, religious, legal, and what, I'm agreeing to the attention that sexuality may be affected, or sexuality or sexual health is affected by various factors. So one of it is the age. At what age are you? A child may have different needs, sexuality needs compared to an expressions different to a 25-year-old to a 60, 70-year-old. And we need to understand that it's issue also related to a partner. It's affected by the partner. What partner do you have? Do you have one or not? Are you married or not married? Do you have a couple? Or do you have someone in your life? It's also affected by that. It's also affected by our previous experiences about sexuality or sexual health issues. So it's also affected by that. Some people were abused. Some were told this is a taboo, not a go area. For that reason, when you are approaching issues of sexual health, the stigma there, once you touch that area, it's like you are against some laws or whatever experience you have gone through. And also when we are going there, we go for culture and religion, especially in our culture in Eswatini. The Swazi culture treats sexuality and sexual health in another way. So it's also affected that how you express and experience your sexual health is also affected by your religion. You have Muslims, we have Hindus, we have Christians, we have all different religions, tradition, Swazi culture, religion or tradition. So different religions have different roles they play. So it's very important to understand people's spirituality at this point in time and culture, how they treat sexual related issues. So thus affecting individuals' expression and experience of sexual related matters. And also it is affected by health comorbid conditions. You may find that a patient has a cancer, but there is also certain comorbid conditions. Some will have mental disorders, some will have hypertension, some will have diabetes, and some will have different comorbid conditions that they may have that will affect the level of enjoying their sexual health right and experiencing to the fullest level their sexuality. And also, when you talk of it, also affected by psychosocial history that may include issues of depression, anxieties, traumatic stress and stuff. So they play a major role in how you experience sexuality. So when patients are stressed or you have anxiety, fear, and stuff, you find that it has an impact on how your sexual health gonna be or how you experience your sexuality. And then also it is affected by symptoms and side effects of drugs. When you talk of life-limiting and threatening conditions, you find that they are undergoing different aggressive treatments, like they are doing chemo, they are doing dialysis, they are taking some certain drugs that have optimal side effects. We will have opportunity to see some of the side effects that we have, and you find that due to those chemo-related therapies or drug therapies, they have some side effects, or they have some symptoms, nausea, vomiting, pain, most of the distressing symptoms, and then they will have difficulty or their sexuality will also affected. And then we also talk about the issues of treatments themselves. Their treatment like chemotherapy, radiation, surgery. We have experienced it in palliative care, especially with our patients with bowel cancer, penile cancer. We will find that the treatment will involve removal of the labials and the removal of the penis. So we also have the disease itself. It might be cancer or whatever condition, especially cancers here, or organ failures, or the disease itself. You find that it's pathology or progress. or prognosis has an impact on the patient, and the patient trajects through the disease, it has some negative effects on the patient's sexual. So there's a lot that we can think about. These are the most factors that are affected. So if your patient has one of these factors, you may find them experiencing sexuality in a different way, or their sexuality may be affected. Once it's affected, it's a major part of the patient, and then the other systems of the patient will also be affected. So maybe taking a snapshot on the sexuality across the disease trajectory or the illness trajectory, we understand that our patients may go through 4 stages trajectory. So there's the first part where they are diagnosed, and at diagnosis, we may find that when everybody is told the bad news of the diagnosis, rather they will be thinking about sexuality issues. They will be more concerned about the treatment, the journey, any options available, or is this a true thing? How can I fight it back? This cannot be me. You know, other than thinking about me losing my sexuality or losing my partner or so ever, they may not be thinking about sexual issues here. Not saying that they can, but majority of the patients might not be thinking about this. It's something we can put into study to see the sexual needs of patients across these 4 stages. Study for this one, maybe cross-sectional study. It can be done, and then we may see the patient as they move across the disease, or we can just do one study longitudinally and see how they will be progressing over time. So another one phase that the patients may go through during disease is then once they are diagnosed, they move to treatment. Even here, even though at some point they may need some closeness and relationship, partner support and stuff, intimate, but most of the time you find that their desire for intimacy and stuff, it goes down, even though sometimes treatment side effects may give them some effects on sexual issues. But you may find that the most concern during treatment is when and how can I finish this treatment. But they may need some intimate relationship, as sometimes they may lose self-image due to treatment side effects, as we have seen in that side. And then some symptoms coming up and side effects. So they may have some intimate needs as they are going through this treatment, and some caregivers or the partners may be affected sexually too. So they may have some need here, but not as much as it was in the start. But then when we move towards recovery and survivorship, when they finish their treatment, most of the time their concern is, how can I move 100% away from this difficult treatment time? How can I not go back to the chemo, radiation and stuff? How can I live an independent life? It's like, no, even though we may not say they want to go back to normality, because they may not regain normality at this point in time. But when they go for survivorship, you may find that they may want to recover quality of life based on where they are, which then will bring in the issues of intimacy and stuff. With the other factors that may affect how they experience and express their sexuality issues. And then we move to the last phase in the disease trajectory, which is the advanced disease and the end of life. We know this, we talk of life expectancy of 6 months or so, or less than 12 months. So if the survivorship is not lasted that much, or recovery, then we move to advanced kidney disease. At this point in time, in the past, with us Hospice, they used to come to our main area, the office, in the center in Matsapa for hospice care. But now, due to multiple factors, financial constraints being the number one, and funding for that services, we don't have it, but we have the home-based hospice palliative care service. So at this phase, most of the time, they have the high need of an intimate time. And in the hospital settings, you find that they may need the closeness of their partners or family members to be close to them, because now they can tell that indeed they are approaching the end. So they may need the closeness of their loved ones. And at this point in time, they find that one of the negative effects or barriers faced by this patient, other than the professional barriers, you find that environmental barriers like privacy issues, you find that there are not enough beds or to accommodate sexuality needs of those patients, especially issues of privacy and stuff, and the issues of promoting the intimate time and closeness of family members. So you find that they have those needs. So in short, sexuality issues, they cut across the disease type, so they have the needs. But what I want us to know is that we need to understand that as they move with the disease trajectory, the needs skyrocket. So the best way is that some of the time the client will not initiate the conversation, but you need to talk about it. So then the impact of sexual function on female sexuality, what we need to understand is that sexual function and sexuality are not the same thing. Sexual function may be a contributory effect on how the patient is experiencing sexuality. It might be part of sexuality, but sexuality might not be part of sexual function. So for the female sexuality, what we understand is that the diseases that they are going through, the patients, they have different effects on the sexual function of those people. So for the females, we may experience decreasing interest in sex or sexual intercourse, and there may be changes in arousal, and there may be changes in the vulva and vaginal dryness. So you find that now they have dryness. Some of the drugs used, they have a side effect that will lead to vaginal dryness, and there may be changes even to experiencing orgasm, which is another very important issue in the sexual arousal cycle, which is the desire for sex and the arousal, the orgasm. And sometimes those that have an opportunity to have sexual intercourse, they may have it painfully, and sometimes they have ovarian failure, so that they even don't have disturbed menstrual cycles. And then there's also altered fertility sometimes. So another thing that we may see that the impact of sexuality, which sexuality includes the issues of body image and self-esteem, and it is very affected during the disease of that condition, especially as a result of the disease and treatment. And they may also experience depression and anxiety, and there may be some relationship difficulties under the sexuality. So likewise, within the males, they may have decrease in desire for sex, and there may be changes in arousal, especially the fact that the spontaneous erection is faced with challenges. So they are faced with challenges with that one. So they may find the erectile difficulties and sometimes ability to achieve or maintain erection and firmness of erection. You find that these patients have a difficulty for that due to the disease treatment or the condition treatment they are taking, and they have ejaculation changes. It may have changes in organism too, patient intercourse, altered hormones. Even the females, they may be altered hormones, and also they may be altered fertility. Sometimes it may be permanent or temporal. And then also with them, their sexuality issues also affected psychosocial issues, including body image altered, and it also affects their self-esteem. They may have depression and anxiety, and they have relationship difficulties. So whenever you're approaching this patient, you need to understand that how is the treatment they are taking affecting their sexual function, because it has an impact on their sexuality. And also, how does their treatment affect their psychosocial level or psychosocial status, especially in terms of body image? We have seen those people with alopecia due to chemo. They have some will have the cancer taking the eye. They will be chiastic and stuff. So we need to understand all those things. And then we have the issues of depression. So some of the treatments, they have come with depression and anxiety. So if you manage those things, how does it affect the patient's sexualities? And also we need to understand that some of the medications we are using in palliative care, especially whether for management of the NCDs or as the adjuvants, they have some impact on the sexual function of the client, and then they will contribute to challenges in the sexuality of the patient, or they will then affect the sexuality of the patient. So I have these drugs here, but I will not read all of them, but I will just mention a few of them. So if the word is written black, so the ticks undergo which areas of sexuality are affected by that drug. For example, we have anticonvulsants in palliative care, and for example, we have CPZ, phenytoin. And if you look at these drugs, they have possibility side effects. They affect erectile dysfunction. So for the males, you experience this, especially for carbamazine and phenytoin and valproate, almost all of them. But then phenytoin and valproate will lead to loss of sexual desire. So the patient will have loss of desire for sex, and then but carbamazepine or CPZ will lead to ejaculation disorders and will lead to orgasmic disorder. And then antidepressant and tricyclic ones, the amitriptyline one, which is also available in my institutions, look at its effect on the patient. It affects erectile dysfunction, it has a loss of sexual desire, it leads to ejaculation disorder, and it has orgasmic. So if you are prescribing amitriptyline, you need to screen the patient on their sexuality experience and expression. So you understand how has this affected them. So I don't know if we could do a baseline study and then follow those patients who are taking amitriptyline as an adjuvant for neuropathic pain. You may find that in some time they lose erection for the male, and then both the female and male lose desire for sex, and they have ejaculation issues, and then they end up having orgasmic disorder. So there are many, we make this downward. You can see the even metoclopramide, the one used for nausea. So when the symptoms they come, even though the symptoms are low, they have a negative impact on the patient, but the side effects of the drugs used to deal with that one will also have side effects. Even antihypertensive drugs, they have those effects. If you have a patient with atenolol, carvedon, and anapril, you will find that the male will have erectile dysfunction, and they will lose the carvedon leads to sexual desire, ejaculation issues, and orgasm issues. So yeah, so most of these drugs, and more and more we may think of them, but what I wanted us to understand is that these drugs, they have those effects. If you go to the benzodiazepines, you can see them. Even the antipsychotics, chlorpromazine, actually this is the CPZ one. So all of them, they have they have the effects on the sexual arousal cycle of the patient. So we need to understand them. For example, CPZ even leads to priapism. So we need to understand those issues. And then we're going to understand the changes that happens in the sexual desire. So for this one, this graph, which one? I wanted to point. Yes. So this graph is for the sexual response cycle. So showing us how it is. Sometimes we may say arousal or desire for sex might be spontaneous, but sometimes we need to be, it can be an arousal or a responsive one. So this is the cycle that the patient will go through. But I want us to focus more on this one, which is the sexual arousal cycle or the cycle. So this is how it goes. There's a fantasy, and then the emotions, and then the body, and then we have the cycle going up and again. Once you have the body responding, and then it goes to the brain, and the cycle goes this way. So the first thing that we need to understand is that in the brain, when the fantasy is thinking about what the patient is thinking about, or the knowledge that the patient is there, it affects the brain. And then the emotions of that one, there must be emotions involved. So that may lead to issues of trust, love, and the intimacy that is involved. And then what is going to be the body response, which is the erotic pleasure that the body will have there. But then we need to understand that due to the condition and treatment that are being taken under palliative care, then there are breaks that happens throughout the patient. So in the body, you will find that there's pain or inappropriate stimulation. So if the body has been inappropriately stimulated, then the body will not, the brain will not process that one well. So this will break the sexual arousal cycle. And then also have the sexual side, which is the emotions. Once you have the brain sending the stimulus, and then these emotions must be there. But then when there's anxiety and fear of failure, grief, loss, whatever the patient is going through, it then have this brain. If the emotions, if the patient doesn't trust whatever that is happening, and then there will be no erotic pressure at all. And then the brain is easily distractions. If there are distractions, sometimes there's no privacy issues and stuff, you will find that this cycle will be broken. So it's very important for us as clinicians to understand the sexual arousal cycle whenever we aim to help this patient build a good sexual desire, that we understand the cycle, how does it move, so you can understand which area is breaking the desire for sex. So you need to understand these three areas, which one is broken. If it's pain, maybe affecting this area. If it's anxiety, it's affecting this area. If it's issues of distraction and privacy, and then it's affecting this area. Then when we are dealing with these issues in the setting, whether hospital-based or where, you will be helping the patient to break this cycle. Once these breaks are removed, and then we know the patient is going to do well. Okay. Okay. So now we have the vaginal symptoms that comes with this. So what happens is sometimes chemo and other aggressive treatment, they push patients to early menopausal symptoms. So they will be presenting with these symptoms to show that there is a problem in the sexual function of those patients. You will find that once they have these symptoms, which can be presented by these signs, it's a sign that they are presenting symptoms of early menopausal predisposed by the condition. So you find that there's genital dryness, decreased lubrication with sexual activity. So you may find that you may need some lubricants there, discomfort or pain during sexual activity. So when they have this, and then during your examinations, you will see these presentations, this sign. to say that this is what is present. For example, genital dryness, you will find that when you're examining genital, you find that the vagina is decreasing moist. So when you're doing your vaginal examination, this one will be the presentation with these problems. And then also we have the change in the erectile dysfunction. You will find that there's a difficulty in achieving erection. The person will say, I have difficulty in achieving or maintaining the erection itself, or they have insufficient firmness for penetrative intercourse. So the penis cannot be firm enough for penetrative intercourse, or the male has loss of spontaneous erections. The men understand better that sometimes they have spontaneous erections, even sometimes they will have no responsive erections, arousal actually. Or loss of nocturnal or early morning erections, you find that in the morning there's no early morning or nocturnal erections. So yet this must be there for a normal person to say that indeed he has a good erection. So if there's a nocturnal or early morning, it's a problem. That's what advisors say make immediately. So for that one, that's one is very good. The patient said that when I'm waking up in the morning, but my penis is not erect at all. So that one we find that is not there. And then we have to understand the mechanisms of erection dysfunction. So we find that sometimes some conditions will lead to nerve damage, and some will change the blood vessels that supplies the penis. And then, for example, when there is diabetes mellitus, it will affect also the blood vessels. Sometimes other cancers will lead to changes in hormones, and sometimes stress, performance anxiety on the side of the men, and depression will lead to erectile dysfunction. Sometimes a combination of these will lead result to erectile dysfunction. So we need to manage all this and find out if any of this is present in the patient. If a patient presents some of these issues, he is at risk of an erectile dysfunction. So whenever that one is presented, you will be able to identify where is the problem and then be able to support the patient as possible as we can. Okay. Right. And then also you may find that on the side of the male there is ejaculation dysfunction. You find that sometimes they will have delay or premature ejaculation. They will say that I take time to ejaculate during sexual intercourse, or they will say that I ejaculate as early, maybe during it before play, they will say that they are ejaculating. So we need to understand that pain ejaculation, some will say they are ejaculating in pain, some will say leaky or no ejaculation at all, I don't have it, or retrograde ejaculation, or sometimes there's urine during ejaculation. So these are some of the changes that will come with some of the problems that these patients will face. And some will have a change, these conditions will impose change in organism, and there will be change in the orgasmic sensation, there's decreased intensity, and sometimes there's increased intensity. So whether it's too much or it's less. And some will have dysorgasm, which is very painful, and also orgasm at all. Some don't have it, and then you find that that's a problem, and it's affecting the relationships between the two partners. And also these life-limiting conditions, they also affect change in fertility. Fertility is a different story when it comes to sexuality, but it affects the issues of productivity and reproduction. So this must be discussed with the patient before any treatment is taken, so that whenever any treatment has effect to temporary or permanent fertility, it must be discussed. For example, when a patient will be done total hysterectomy, the ovarian cancer that will take all ovaries. So that one will affect when a patient will take prostate cancer, they will affect their fertility. So we need to discuss with the patient so that if there are any possibilities for preservation of the fertility, they could be done. Sometimes getting oncology specialists, they do help much, even though in the country, in Eswatini, we don't have the oncologist. We hope that in the future they can help us with options on how maybe that fertility could be preserved if that one is desired by the patient. And then we also have one change, as we've mentioned, sexuality goes beyond the sexual function. It also changes the body image. So we live in our bodies yet more than our bodies. That one we also understand that even though we are in our bodies, but we are more than our bodies. And the body is the medium through which we experience our lives and showcase our inner being. So we need to understand that the body is a very important aspect of the patient, and it's a very important aspect. This is how we express how we are, our inside. This is how we express how we feel. So, and the body image consists of three components that are very important. One is the body reality, the body itself. How is my body? How healthy is my body? How beautiful do I look like? You know? So the body itself is very important. The reality, how I am, the body ideal, the beliefs and ideas about how the body should be like. And this one is very important. You can tell when people have affected self-esteem, you find that they have a different body ideal. Some will have people who are influencing their body ideals, like how should a man look like? How should a woman look like? So whenever there's been some mastectomy or some operation that have altered their body ideal, that will alter the patient's body image. For that way, it will affect what? The patient's emotions, which is the key area in the sexual arousal cycle. And then also we talk of the body presentation, efforts to maintain an attractive social appearance. Everybody, excuse me, wanna present his body in a different way. For example, he will want to bath, the ladies wanna make up, the men wanna trim their beard, yet they wanna, you wanna wear like, wanna be a cave as well. I want my boobs to be like this, I want my bum to be like this. They go extremes to the level of beauty therapists. I heard that even in Eswatini, in the private sector now we have beauty therapists where people go for body surgery so they can change how they present themselves. So this is the body image. So these conditions that we are having, they have impact on the body itself physically through the symptoms and stuff. They have an impact on the body ID, how the patient believes and thinks his body should be like. And they also affect how the patient presents the body. That's why in sexuality we encourage issues, even if they cannot make up themselves, if that's how they want to present themselves, we need to present that one to them and help them do that. For that reason, palliative care requires a multidisciplinary team. Beauty therapists or practitioners, they play a major role in fulfilling the sexual arousal cycle, in shaping how the body image is. And then sometimes medical conditions I've mentioned, like cancer and its treatment, they affect the equilibrium in these components. Thus, they compromise the self-esteem and emotional well-being of the patient. As I've just mentioned that, it's very important to understand that whenever there is a condition happening, for example, in the country, we are seeing more people done mastectomy, breast cancer. Some of them are done the removal of the labias. I've had patients who have been like this. One patient, when we were discussing sexual issues, this woman said, I'm scared of getting into the relationship because of what? My body image. I feel like I'm half a woman because of how I'm dressed. How should a woman look like? And actually, my hair soul rest in peace. She even said, how will I look like in front of my husband as a woman when we are in the bedroom? So those things, they affect their sexual arousal cycle. The extent to which appearance depress attention to an extent altered sexual self. So this one is very important to understand that this is how we appear outside also affect the sexual self. And then also these conditions have an impact, they change relationships. You find that now that there's this partner who is diagnosed with this condition, then the loss of sexuality will change the relationship in the family. And the impact of sexuality should not be underestimated at any point in time. So whenever there is a serious illness or life-threatening condition or life-threatening illness, we need to embrace that it will have significant impact on the relationships of the families or couples. So quality of sexual relationships significantly influence sexuality, body image, and self-esteem. So it is, if its foundation are based on strong sexual attraction. What does this mean? It means that we need to understand the sexuality relation or the sexual relationship of every couple. Where is the centerpiece of it? So if then the relationship of these two people is based on how attractive the other person is, and what was the attractive element? Was it character, or was it body related, or was it something they could see? So if then it was related on something that is already altered by the serious condition, you will find that the attraction between the two has crumbled down, and then their sexual relationship will be affected. Sometimes you find that sexuality, the sexual arousal cycle plays a major role in knitting up relationships, keeping couples together. If they are not going to have enough sexual encounter and find that the relationship goes down, and then with the presence of this life-limiting conditions, you find that the one is affected. So common compounding factors usually missed by us like clinicians is we miss the vulnerability of this relationship and fear of the rejection and feeling of undesired. Emotional, so if you fear of being rejected by your couple, or feeling that I'm undesired by my husband or my partner, may lead to serious issues. And sometimes we ignore the issues of emotionally overwhelmed and miscommunication between the partners. So it's very important to understand the communication between the partners and how each one of them feels and how each one of them feel vulnerable at this stage, so that we can support them and help them grow together as a couple and support each other until the end. And sometimes we see that through these conditions, there are changes on the partners. So you find that there is a change in the partners. The partner may feel that fear of causing pain and discomfort during sexual activity. I have one client that I have met. So I was able to meet this patient, and one of the things, the patient was a female and the husband was not the patient. And the husband felt that the patient is rejecting or denying her conjugal sexual rights. So yet the patient was scared of discomfort during the sexual activity. So when we were discussing those issues, you find that the partners, so they then change how they were before the diagnosis of the condition, or their relationship or their reaction and behavior towards their partner pre-condition is not the same now. So they may feel unwanted or unattractive or rejected due to decreased sexual activity. So if then the other person is not sexual interested in sex, then the other partner will feel rejected. And sometimes the change of partner roles, you find that the husband or the wife has moved from being the lovey-dovey or partner to a caregiver. So now he has assumed the role of being a caregiver. Most of the patients that we care for at hospice, if you assess the caregiver's sexual needs, you find that they will say that I've accepted that he is like this, my duty is to care. So they have moved from the sexual partner role to a caregiver. So that one also changes and affects the relationship, because now the patient is not looking at the partner is not looking at the patient as a patient now, but is looking at the patient as a patient other than a partner. So sometimes they may be worried about the potential loss of a partner, which is we call anticipatory grief. They begin to perceive themselves as they lost their partners. You will hear the partner say, when you are in session with them, saying, he is as good as dead. Not just that, I've decided to consider him not here to fulfill his conjugal rights. And then by that way, this affects the relationship or the sexuality of both parties, the patient and the partner. So other considerations that we need to think of when a patient is sick or is hospitalized. As clinicians, we need to be cautious of the symptoms. We need to understand that there is pain. How does it affect the patient? Sometimes symptoms of shortness of breath will affect sexuality. Fatigues and weaknesses affect sexuality. Nausea and vomiting, dry mouth, cognitive changes, dementia, and other issues that are coming, delirium, and many more that comes with these symptoms. They really affect the sexuality of the patient. So whenever we are approaching them, when we are managing this, it's sometimes better to even ask, how does these symptoms affect the patient's sexuality and sexual experience and expressions? And also the environment in hospitals and other setups, especially here. Now we are seeing that even at home, patients are taking oxygen. And we have a patient, as I'm speaking, who is on oxygen therapy. And he is having difficulty. One time he asked me, Mr. Master, I'm worried. How will I continue making my wife feel a woman? Because when it's time for sex, I cannot perform. So in the arousal cycle, is now at the emotional level. I can't perform, even if I have the fantasies, I can't perform because I'm oxygen therapy. I'm going faster to Disney. And we have to discuss with him how best they can do this. I haven't gone back to check if they tried those alternatives we discussed with them. Some on IV tubes, some on feeding tubes, some on hospital beds. We know the hospital beds are a little bit smaller than this one. So they can't accommodate too, even for cuddling. Partners cannot go there. For that reason, we can even recommend for sexual partners, if they have sexual consent, if they go with provisions of double beds that's absorbed. So they have time for cuddling, you know. And they go privacy, you find that they want their beds now and here. They are maximizing capacity of the facility. So there's no time for cuddling and sexual conversation between two partners. So there's no privacy. And the clinicians coming in and out, you don't know privacy. And sometimes the environment they are in is not inviting. So these factors may lead to or be barriers to sexuality expression or sexual expression and affect the sexual arousal cycle of the patient. So when we are putting interventions, we need to attend to the biological factors, psychological factors, social cultural factors, and interpersonal relationships or interpersonal factors. So we need to deal with this because all of these, the biopsychosocial model for sexual health will help us achieve and help patients achieve good sexual health. So some of the intervention may include psychological or counseling. We talk of psychological may include of cognitive therapy, we have motivational counseling, we have cognitive behavioral therapies and others that we may have. So we may need counseling of both partners, if none, we may need marriage counselors whatsoever who can help that one. And sometimes the partner and caregiver role, we need to talk of the support and assistance for the partner. So we need to engage on those issues and how best we can support those people. And there are non-invasive assistive devices sometimes for sexual function. We may need those devices like dilators, lubricators, moistures, sexual enhancers. So we may recommend this depending on the need of the patient. So for sexual function. And may manage the disease and the treatment-related symptoms as normal, like pain, nausea, neuropathy, dyspnea, and other symptoms that may be presenting. So then the patient may be able to express his sexual needs. Sometimes we encourage pelvic floor physiotherapy, allow them to have those squats and stuff, so that the pelvic floor can be exercised very well and other pelvic floor therapy activities. Sometimes also referral to a psychology or urology, where there's the project as indicated may be a good intervention for these patients. So you need to find out the cause and what is the problem in the sexual arousal cycle of the patient or in the sexual needs of the patient. If it's body image, we need to deal with the body image. If it's anxiety, depression, we need to deal with that one, and relationships, we need to deal with that one. So we need to know where is the problem. Is it in the sexual function area? Is it on the psychological area, psychosocial area? And then we are able to deal with that one. And then another thing is communication. Sexuality is affected by communication. So we may encourage our patients to talk open with their partner about their feelings, emotions, and physical needs. So how are they feeling physically? How are they feeling emotionally? There is no sexuality need met without communication. And then we need to encourage the patients also to be concerned about how their partners feel too. If their partners are feeling concerned about them, but they need to also be concerned about how their partners are feeling. And also we need to encourage them to plan ahead. Whatever, even if they are planning for sexual intercourse, they need to plan ahead and deal with pain on time and deal with fatigue on time. And they need to take things slow gradually so that they may adapt and to the new normal way of doing things. And that way, we need to encourage them to be patient. So they need to be patient with each other as they are coping with the new normal. Another thing we can do is to improve intimacy. So we need to, when we are dealing with intimacy, we deal with the emotional and the sensual and sexual intimacy. So we need to deal with the emotional intimacy, sensual intimacy, and sexual intimacy. So we need to deal with the three. And we need to find out which one is affected. Is it the emotional intimacy? Is this the sexual intimacy? Or is it the sensual intimacy? So there are different sensual activities that they may have, handling of hands, showering together, and many others. And then there's also this therapy they call senses therapy. So whereby they're learning all your senses and how to improve your sexual needs and then helping with your partner. So I've attached this video link here, it's on YouTube, so you can learn more about the senses focus. So you can just click it, it's there. It will be uploaded into our resource material, so the presentation will be there. You can just go there and use this link and then learn about the senses focus and how it can be done step by step. And then you can help your patients to practice it so they can improve their intimate relationship. So you may encourage the issues of non-interpersonal interactivities, as I've mentioned that one, so they can help the patient to, for example, cuddling and other stuff can help them to enjoy and improve their intimacy. And then to improve the sexual desire, we need to help the patient to be aware of responsive desire and spontaneous. If you remember that cycle I've shown about the responsive, sexual responsive cycle, so you need to know which one is affected for that patient, and then you can provide counseling. So you can know the responsive cycle for their patient desire. So as I've shown it above, so you can check how is the spontaneous desire or is the responsive desire? When you're talking about this, sometimes you may not have the desire for sex, but when your partner is touching you through the sensitive focus, you may then be responsive to that desire, then you have a responsive desire. You may not be willing to desire to have sex at that point in time, but through the partner's activities, touching and stuff, you end up going for sex. And there's the difference between orgasm and satisfaction. So sometimes you may have a great experience and be satisfied without orgasm. So we need to encourage them, educate the patient on those things. But sometimes it's okay to have responsive desire. And the partners need to understand one another. If one partner has a spontaneous sexual desire or has a responsive desire, so that they can support one another. If it's responsive, then the other partner will have to assist the other partner to have the desire, so that the responsive desire, then the cycling will go on and go on. And then sometimes of counseling and meditation, it will help. And these are the benefits sometimes that comes with meditation. It manages anxiety. Anxiety affects the arousal cycle. Stress affects the arousal cycle. Pain affects the arousal cycle. And other things, concentration and other factors. So self-esteem affects the self-arousal cycle. So we need to encourage sometimes the meditation and mindfulness for those patients who can. And then we need to understand that how we can best improve erectile function. But here you may need the urologist, you may need the gynecologist, oncologist for those with cancer, or the gynecologist. They can have. This one is the penile implants for those who have erectile dysfunction. So this one can be inflated, so the penis can be erected, and then sexual activity can happen. And then these are penile rings. These are constriction rings that can also be used. So sometimes they have side effects, but they can be used to maintain erection. And then for those who have poor erection, to maintain erection, so these ones can help. And then we have also this external penile prosthesis. So they use to support the penis, so they are put there, so they can also be used. So you can encourage or refer the patient to gynecologists and urologists to deal with these issues. So they will help in dealing with the external erectile function. And there are also drugs that can be prescribed for erectile to improve erectile function. And then also for those who have vulval or vaginal symptoms issues due to different therapies. So we can help with the moisturizers and lubricants. So the cells cannot be painful and moisturize the vagina. They can have dilators, because some of the therapies will constrict the vagina, so the patient cannot achieve good coitus. So we have those dilators. I'm not sure in the country, I've never seen a sex shop. Maybe it's affected by our culture, I'm not sure. So, but in South Africa, there are the vibrators, and then there's pelvic floor therapies, physiotherapies, yeah, and then the counseling and psychotherapy can also help. So these are the lubricants and these are the dilators. So they can use it. These vibrators and dilators, so they put batteries and then they help those patients. And then also patients, we can encourage them that during or immediately after chemotherapy, when it's possible, the partners will not be exposed to body fluid. It is very important that they use condoms. So we have male and female condoms, so they can use condoms. And then we also have these dental dams for oral sex and others. Sex, so they can use this for that, at least for past 72 hours after receiving the chemo, so they can use this thing for that sex life to be safe. And then I've mentioned a lot of barriers in our practice, especially for us clinicians. We need the time to assess and give our patient time to address the issues. And there's the privacy, there's little or no training in sexuality. and then awareness about its impact on the patient's life, and the comfort levels, pain management drugs, find out there are no drugs, and sometimes we are not also comfortable ourselves. Assumption that sexuality is not important than other problems. Sometimes we consider it as a private issue and a personal issue. Sometimes we assume patients will bring it up and they will not. And personal beliefs and values are different, beliefs, cultural issues, experiences. So they affect us. And then communication difficulties. We can't communicate in a way that patient will understand us. So yeah, sometimes the ambiguities are regarding the professional responsibility. Some patients will say this one is for the midwives, some will say that, and some will say other issues. So let me just go through this framework. So for us to provide patients with support with good strategies in adapting to a new sex life, it will require us to understand this implicit framework, which is permission limited information, specific suggestion, and intensive therapy. So you can just check it on palliative care books, especially palliative care nursing books. They have this one explained very well. So on the permission phase, which is the initial phase, here the clinician, you are giving permission to discuss the sexual concerns and legitimize the topic. So when you are getting the permission to discuss sex, it's legitimate the topic. For example, at Hospice, we have this open question where we say, we need to ask the patient if we can discuss sexual concerns or sexual issues. Then the patient can say yes or no. So then once the patient says yes, we can keep on going. And then now we are at a position where we can discuss this issue. And primarily, it is important that a private control forum is assured. So we need to ensure that when we discuss these issues, we are in a private and controlled space. And you need to create an atmosphere of trust. The patient should trust you. And in my experience, it is possible that the patient will trust us. So we need to ensure that we assure them of that whatever you're going to discuss here ends with you and the patient. And a brief assessment as part of information gathering for all new patients can be helpful. For that reason, especially when we're doing an admission of the patient, we need to get the baseline of the patient's or the caregiver's sexual needs or concerns, so that we can know the concern of the patient, the sexual needs of those concerns at baseline. So for that, we even recommend that even the hospital-based file or admission form should have that, so that data could be considered, so that patients could not be deprived their sexual rights as the WHO requires us to be provided and honored. So asking the patient to narrate their story is considered the most effective way. Other than you telling, let them narrate how their sexual life is to you. Allow the patient to identify the pattern of sexuality in their life is very helpful and help determine if and when more detailed assessment should be conducted. So if you allow them to state their concerns and to you, it helps you to know if there's more detailed assessment required or not. And once the existing social problem has been established, at this time, it's a very importance to the patient's needs to be understood before the most appropriate management is understood. So offered. So you need to understand exactly what is the problem and what is its intensity. Then from there, you can decide or make a decision on what management is going to be. And then another thing that we need to do is that then we move to legal information, not detailed one. For us as clinicians, we are not going to give more. So the clinician at this point in time will provide non-expected information. So what does this mean? It means it eliminates omission of providing sexual health services. For that reason, it's training. All nurses, I don't know other cadres, but all nurses are trained on sexual health and sexual and reproductive health. Why? So that you can be able to have basic information that you can provide on related to sexuality and sexual health. For that presentation today, we provided you just basic information when it comes to related to sexuality and sexual health, empowered you to identify the needs and possible interventions that can be there, and the meaning and effect of other things. And actual and potential problems are addressed following the assessment. And patient and families should be provided with clear, understandable information and assessment about the treatment options available to them. What can be done, what can be used, and what options can be taken. And this should include verbal and written information to help patients accept and adapt to the altered sexuality and relationship changes. So they need to understand how to adapt to the change in relationship and sexuality needs. So that information will help them do that. That's the information we're talking about. And you need to educate on the use of sexual arousal cycle. As I've talked about the sexual arousal cycle, so you need to explain to the patient, educate them about the sexual arousal cycle. How does sexual arousal happen? And what are the problems resulting from social stress and physical changes experienced? Explain all those things and how they affect the sexual arousal cycle, so the patient can identify those issues and cooperate and work together in addressing those problems. And it is crucial to dispel any myths and misconceptions. There are many myths out there, there are many misconceptions about treatment, about sex, about sexual experiences. There are a lot of myths. We need to address those myths. Facilitate informed decision-making regarding treatment modalities and quality of life. So this is another platform that we need to understand in this program. We need to get permission, discuss, identify the problem, and then have the clinical information that we need to do. And then once you have provided the clinical information, basic as non-expert knowledge or information, we then move to specific suggestions. So whereby we are giving information about strategy to help overcome problems related to disease and treatment. It is an unethical at this point in time to encourage patients to disclose highly emotional information without trying to resolve the issues and reveal. So and this need to be specific on what exactly can be done. So you can give specific strategies. I've been sharing some of the strategies in the previous slides on what can be done where and which area can be addressed. For example, when there's a sexual function issue, these are some certain strategies that can be used. When there is an image issue, these are something that can be used. When there's a relationship issue, these are something that can be used. When there are partner-related issues, these are things that can be done. So that's what we need to suggest to them and be able to do. And then we have the intensive therapy. So the last one is the intensive therapy. So before the patient is exposed to emotional stress of discussing sexual relationship issues, it is important to know what is available. So when we talk of intensive therapy in the implicit, we talk of what is available in the country. So we need to do our own local assessment to see what is available. For example, where is the condom? Where can I find it? Where can I find lubricants? So if we know those, I'm making just an example. Where can I find a gynecologist? Where can I find a psychologist? Where can I find a social worker? So intensive therapy may mean referral to a clinical psychologist, sex therapist, a social worker, or a specialist. So the term can mean intensive therapy. So what does this mean? You find the permission, you know the problem, you give information, and then you then move to specific suggestions, and then you can then now say, I have tried 1, 2, 3 options. I've tried to know the problem. I've found I've given the information. I've given specific suggestions, but they are not working. Then now I'm going for an in-depth therapy, which is referral to a therapy. Or then these specialists may use different modalities to do that. Psychosexual therapies may use physical devices like vibrators or pharmacological interventions or psychotherapeutic strategies to deal with these issues of the patients. And the sexual workers may include behavioral approaches, cognitive approaches, psychodynamic approaches, and this may help the patient cope with the grief that they are losing their sexual and cope with their changing relationships and facilitate sexual expression throughout the disease journey. Yeah. So there are things that you may need to work on as clinicians moving forward, or things that you may need to change in our setups, whether hospital or whatever. We may need to create an environment that accepts and encourages intimacy. That's what we need to do, so that we need private rooms with lockers, double beds, private signs, information booklets in the facilities wherever possible. And then we need to be more cautious of resources like massage, therapy, touch, counseling. We need to be more cautious about those to improve self-esteem and coping strategies and reduce pharmacological challenges with sexual dysfunction. And then we need to include assessment and start it at diagnosis and continue throughout the disease trajectory. So sexuality assessment should begin at diagnosis and continue throughout the disease trajectory. Thank you so much, colleagues. I think this is what I can present as far as sexuality concept in illness is. So may I leave this for any questions, any contributions, any concerns that may be there. So, yep. Yes, that's what I can share. I don't know if we can do any question or we can have but that's what I can share with us all as far as sexuality in illness is. So you can visit Scholar to see investigations or interventions done in this intervention that we have had and the changes. So we have tried to break each change in small pieces and the interventions does, so we can understand how does each area affects the sexual arousal site or sexuality as a whole. So we can understand that and then be able to troubleshoot on which area is affected and how we can address those issues. So there's the issues of the sexual function and then the issues of image, relationship, and then we have the anxiety and stress issues. So all those three will fall in the psychosocial issues. What we need to understand is that sexuality is not sexual function, but sexual function affects patients' sexuality. So once you understand sexual health, and patients have a right even for sexual health and to experience a good one. So sexuality, all patients they go through, but they experience and express this in different ways. So how does it affect the patient? And then this one leads us to understand that then the patient is a whole being. If one dimension of the patient is affected, then the whole patient will be affected. For example, if the body or the physical dimension of the patient is affected, it will definitely affect what? The sexual part of the sexuality of the patient. It will affect the spiritual part of the patient. It will affect the psychological part. It will affect the progress that has been going through, the coping mechanisms. So the balance, the equilibrium in all these dimensions will help the patient to move forward. You may be doing all things well, but if the patient is affected sexually, or the sexuality of the patient is affected, or the sexual ill health of the patient is there, not well managed, you may not achieve comfort and a good quality of life. And then we have understood that patients have different needs across the disease trajectory. But what we have noticed is that even when they are approaching the end of life, they may need more intimate time and their sexual needs may go up. They need more closeness of their families and relatives. But then I'm waiting for any question, any concern. or any contribution? Okay. I was here, I don't know whether I was here or it was understood. I don't know. Or it was too much, I don't know. But what I can see, it's assignment. So, thank you so much for attending the session. And we hope this presentation will enlighten us and will empower us on how best we can help these patients and strengthen us, our confidence in dealing with this and understand the context of the patient and support them. I hope so. If that's so, if that's so, so the presentation will be available on YouTube today, so you can check it. I think by 3 p.m. or so, it will be running live, so you can access it today. So thank you so much, colleagues, for joining, and I hope this will help you in your practice while improve the quality of life of our patients. Thank you. Our next session will be on the 4th of December, 2024. Thank you. I don't know what has happened. I don't know. But it has happened. I don't know what is it. So thank you so much, colleagues. I hope if there's nothing I'm leaving behind.